Thank you. Thank you for the introduction, and also thank 3DCon for inviting me for this event, as well as Team Novo for inviting me. Now, Dr. Rajiv has set the ball rolling, and he talked about the pathophysiological defects and how obesity is important. Now, we will walk through a patient. Of course, it's a hypothetical patient. It is a Novo-sponsored event. So this is a hypothetical patient, Sudhagar, a 64-year-old patient who has type 2 diabetes mellitus and obesity. Now a BMI of 32 may not look very high because BMI more than 30 is obese. This is what traditionally we've been taught. But if you look at the actual the guidelines for South Asians, anything more than 27.5 is actually obese, and the 27.5 to 32.5. So he is actually class 2 obesity. So diabetes and obesity with a waist circumference of 97. Uncontrolled HbA1c on multiple oral drugs, and he has a sedentary lifestyle. So this looks very benign, and this is a patient which we routinely see, a prototype patient we do see every day. 50, 60-year-old male, uncontrolled diabetes on multiple drugs, obesity, and not exercising much due to various reasons. Most of the time, the underlying risk, which Dr. Rajiv has described, is not most of the time it's not actually addressed, and the patient was advised lifestyle measures and added one more drug and discussions about insulin. The moment you started, a good number of patients would want to change the doctor, not the medication. So this is also a possibility, and the patient was followed up for 5 years. Now after 5 years, like I said, this is a hypothetical patient. Patient presented with chest pain, and ECG showed an MI. And the eGFR at that time, you can see that it's 30, that's stage 3B or stage 4. Creatinine is 1.8. So this is, again, I'm sure most of you practicing for more than 5 to 10 years would have seen patients like this. They came to a clinic, uncontrolled blood glucose, you advising them exercise, diet, blah, 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 change medications, compliance is not good, whatever reason. Finally, you would see them in the coronary care events. Now, one thing is that the prevalence of obesity and the prevalence of diabetes. We know that at least in India, the prevalence of diabetes is at least 10 to 15%. And if you look at the South Indian states, the prevalence is much higher, 20 to 25, especially in places like Kerala. Obesity, again, 30 to 40% prevalence. Now, it depends what you define as obesity, whether you're looking at the BMI or you're looking at the waist circumference. Now, if you're looking at the waist circumference, the prevalence of obesity is actually much, much higher in adults. And both actually originate, this is a common soil. Patients who develop obesity have years of insulin resistance. They have abnormalities in lipids, as Dr. Madhu has clearly shown. And of course, all of them put them at increased risk for cardiac as well as other cause of mortality. So if a patient has obesity, he is at risk of cardiovascular disease and mortality. Now, if the patient has diabetes and mortality and obesity, he is at a much higher risk of death from any cause, including cardiac causes. This is the AD approach. You've seen many times. First, you look upon if the patient has ASCVD, CKD, heart failure, or if the patient is at high risk for these events. Now, high risk would mean the presence of target organ damage, including albuminuria, hypertension, dyslipidemia, smoking, more than 65 years age, very strong family history. So all these things would come up as high risk at high risk for ASCVD. Now, if you have any of these, not just ASCVD, high risk factors or CKD, you should give agents with proven benefits like SGLT2I and GLP-1RA in this population. Now, if the patient does not have any of these compelling indications to use, you can choose any of the drugs. But then, of course, you should be looking into the patient's weight and the efficacy. And if you see the data, there are drugs which are highly efficacious as well as which promote weight loss. So at least 2 or 3 newer drugs, including semaglutide, whether it's oral or injectable, as well as the dual agonist, GLP-1 dual agonist tirzepatide, both of them falls into that category, high efficacy as well as weight loss, which is very solid. And if the patient has ASCVD, definitely we need to give agents like SGLT2I. Of course, only 3 of them has been shown to have positive effects with respect to CV events. And GLP-1 RAs, at least 2 to 3 of them have shown positive effects about MACE. Now, based on the guidelines, if you see what could have been done differently in this patient with diabetes and obesity, who is 64 years who has a sedentary lifestyle, he actually should have been stratified for ASCVD. Now, there are at least 5 to 6 guidelines which discusses how to risk stratify in diabetes. For example, if you look at the ADA and ACCHA, they actually want you to look into the risk by using a calculator, ACCHA calculator, which is available online free of cost. You put in age, sex, race, cholesterol, blood pressure, smoking status, and diabetes, then you get a risk of future risk of ASCVD. Some associations like ACE do not advise this risk engines and all these things. They just want you to understand that patients with diabetes have something as a very high risk. So you have patients with diabetes who are at least 20% risk of ASCVD at baseline, and they have very high risk and extremely high risk. So these are patients who already had an event. So there are many guidelines which recommend how to deal with it, and these are very different. But bottom line is that at least some form of risk stratification should be done in patients with diabetes, and you have to address all the risk factors. It is not just about treating the numbers. It's not about bringing down the fasting or HbA1c. You have to treat the patient holistically so that the overall risk is reduced for cardiovascular as well as renal outcomes. So this is actually, slide has been shown. This is from the Steno 2 study, which was a very small study. Just 160 patients were randomized, 80 in conventional group, another 80 in intensive group. Now, conventional was actually what was followed at that time was continued. And these patients had a median A1C of around 9%. Those who were given intentional, their HbA1c was at least 1% lower. They were given statins for primary prevention. They were given ACE ARBs and aspirin. And the difference, if you see, 1% HbA1c reduction, 10 to 15 millimeter BP reduction, 10 to 15 milligram of LDL reduction, and aspirin. This is all the difference was. And the study was done for 5.5 years. And at the end of 5.5 years, you can see that half of the people who were given conventional treatment, 40 of them had died. And in the intensive group, only 24 died. So 24 by 40 by 80 and 40 by 80. So you can see there is a clear difference. And the study was followed up for another 7.5 years, and you can see that clearly the benefits of treating early and aggressively, these patients still had lower risk of death as well as microvascular and macrovascular complications. So that is the message. UKPDS has also shown that if you treat diabetes early and aggressively, you have the legacy effect. Here, the legacy effect of treating diabetes, lipids, blood pressure was persistent even after a decade or 13 years. Now, GLP-1 RAs, we know that they have multiple effects. It is not just that they promote insulin secretion. They knock down the glucagon. One, they slow down gastric emptying. It has important effects on satiety. And in the initial years when liraglutide was introduced, there was some data to show that in the immediate post-infarct period, at least in mice, when you give infusions of liraglutide, it can actually reduce infarct size. So there are multiple benefits which are thought to be there associated with GLP-1 RAs, and we exactly do not know how they are beneficial. Semaglutide basically is a long-acting GLP-1 receptor agonist which has a very high homology to native GLP-1, almost 95% homology to native GLP-1, and the half-life of roughly 1 week. And they have some changes in the amino acid so that it is protected from the endogenous DP4 enzyme. And to make it absorbable, there is a substance called SNAC which is added to this, and this actually makes it resistant to the gastric pH. And it has been shown to have very effective in reducing CV risk factors as well as even CV events, which we'll be seeing in a couple of slides. And there are two forms of semaglutide. One is injectable, which is given once a week, which we are still expecting. The oral form is available in India. So coming back to our patient, what could have been done and what all things that we can do. If you look at the efficacy of semaglutide across the PIONEER program, whether used as a monotherapy or used along with other drugs, whenever it's compared with liraglutide or SGLT2I, so you can see that it gives a solid 1.5 HbA1c reduction. Most of these trials had patients between 8 to 9, and if your A1C is still higher, obviously you get more reduction. Similarly, we can see that in most of these trials, except when it is used with insulin, you can get a weight loss of up to 5 kg. Although it is not yet approved in India for weight loss, many a times you do get beneficial effects on weight as well, even in non-diabetes, but this is not yet approved in India. This is data from Pioneer 6. What about the CV safety of semaglutide? There was a study, Sustain 6, which was actually about injectable semaglutide once a week, and when given to patients with diabetes, it was shown that there was a reduction in MACE events. Now that is a third GLP-1 receptor agonist to show a positive effect on MACE. Now this data is about oral semaglutide. This trial actually showed there is a 21% reduction in CV risk or MACE events, but unfortunately this was not significant. There are various reasons why it was not significant, but one of the most important thing is that the duration of study was only 15 months, which was actually pretty short for something like a drug to show beneficial effects on cardiovascular events. But nevertheless, we have a 21% relative risk reduction in the MACE events. Also, another study called SOUL is undergoing with much larger population with a longer duration of follow-up to examine the effects of oral semaglutide on cardiac outcomes. And there is also some data to show that semaglutide, when given to patients with diabetes, slows down the fall in GFR. GFR falls down every year in normal individuals as well as in patients with diabetes. In patients with diabetes, the fall is actually accelerated especially if you have uncontrolled blood glucose. Now, at least there is some data to show that patients who are given semaglutide have a smaller or lower fall in eGFR. And semaglutide, if you look at the benefits, it is shown to reduce inflammation, improves lipid profile, and reduces blood pressure. Now, these are subtle risk factors, but we have shown that, or at least it is seen in the Steno studies, that improving lipids, blood pressure, and diabetes definitely translates to higher longevity. It has shown to have anti-atherogenic effects in mouse models, and renoprotective effects we have just seen. And 1 to 1.5% A1C reduction, weight loss of up to 5, and this is just a median. There are patients who lose more, up to 10 to 15% weight loss. The median average is around 10 to 12%. Of course, there are a few group of patients who do not do well on GLP-1 receptor agonists, but most of the patients do well. And one of the largest barrier is an injection, which is actually taken out because this is a tablet. MACE 21% non-significant reduction with oral semaglutide. Early in the course, we can actually target the patient's cardiometabolic risk profile. No dose adjustments required in hepatic and renal failure. Of course, the drug should not be used in end-stage renal disease, and also in child C cirrhosis, we do not have data. There is virtually no risk of hypoglycemia because the mechanism of action is insulin dependent, so it works only when the blood glucose is high. When used alone or with the agents like metformin or SGLT2I, there is virtually no risk of hypoglycemia. The instructions, this is very important. It has to be taken empty stomach early in the morning and with around 100 to 120 ml of water. Why? Because only then the drug will be properly absorbed, and not to eat or drink anything for the next 30 minutes. This is what was followed in the trials for semaglutide. This makes sure that the drug, which is an expensive one, is absorbed properly. So coming back to our patient once more. So originally, we had not addressed the cardiometabolic risk in this patient, and unfortunately, he ended with a coronary event. But had we been more aggressive in managing this patient, targeting all parameters including obesity, lipids, and other risk factors, this probably could have changed the fate of this patient. Thank you all for the patient listening.